Hello and good morning, everyone. I'm Stephanie Maselli, Media Officer with the National Academies of Sciences, Engineering, and Medicine. And thank you for joining us today for a webinar for the recently released report, Sexually Transmitted Infections, Adopting a Sexual Health Paradigm. To read the full report, you can visit nationalacademies.org/prevent-STIs. This webinar will also be recorded and will be posted on that page as well. And for those of you who are not familiar with us, the National Academies of Sciences, Engineering, and Medicine are private nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience, and they serve pro bono to carry out the study statement of task. The reports that result from the study represent the consensus view of the committee, and they must undergo external peer review before they are released, as did this report. I have with me several members of the committee to discuss the report, but before I introduce them, just a few reminders for you all. This webinar will last 1 hour. We'll start with a presentation summarizing the report by our committee members, and then we'll open it up to any questions you may have. To submit a question, you can simply click that Q&A button on the bottom of your screen. And should you have any technical issues during this webinar, you can contact Zoom technical support. And that number is 1-888-799-9666 and select option 2. Now I'd like to introduce the members of the committee that wrote the report who are here with us today. We have our committee chair, Sten Vermund, who is Dean and Anna M.R. Lauder Professor of Public Health at the Yale School of Public Health and a Professor of Pediatrics at Yale School of Medicine. We have Medina Agenor, who is Gerald R. Gill Assistant Professor of Race, Culture, and Society in the Department of Community Health at Tufts University. We have Vincent Guillermo Ramos, Professor and Associate Vice Provost of Mentoring and Outreach Programs and Director and Founder of the Center for Latino Adolescent and Family Health at New York University. We have Kay Streetmeyer, who is President of Rietmeyer Consulting and Professor at the Colorado School of Public Health. And finally, we have Alina Selganikoff, who is Senior Vice President and Director of Women's Health Policy at Kaiser Family Foundation. And with that, I'll turn it over to Dr. Vermund to start the presentation.
Thank you, Stephanie. If I could have the next slide. So the task that we were asked to tackle from the CDC was to examine epidemiologic dimensions of STIs in the United States, particularly how they have been evolving and changing over the last decade, examine the economic burden associated with STIs as best we could, to review current public health strategies and programs. Now that's a heavy lift. So that's was a big part of the committee's work over the past year and a half, and identifying barriers in the healthcare system and insurance coverage. The whole point of the committee's work was to help CDC and other parts of the government to embrace future public health programs that are meaningful and will have impact, the policies that can nurture STI control, and needed research in this arena. And next slide. We had 8 meetings, half of them in person before COVID and the others after online. We had input from a broad range of stakeholders. We also had 2 lived experience panels. These are individuals who experienced STIs themselves and were willing to share with us their experiences in the health system and in their communities. Persons who have very special ties to patients with STIs, advocates, primary care practitioners, and the like. These were all open to the public, and we also had deliberative meetings where we worked as a committee to write the report. We prepared 12 chapters that are now available online at the end of this webinar, and they reflect our views, but also as modulated by 14 external reviewers. Those of you familiar with the National Academies know that all of its committee reports are vetted by uninvolved outsiders to give their point of view on the validity of what is being written. And so the 14 individuals reflected some of the same expertise that we had on the committee: epidemiology and public health, infectious diseases and medicine, diagnostic expertise and lab sciences, health policy, program management, economics, behavioral and social sciences, health communication, use of social media, and the like. Next slide. We built on some recent relevant reports that we wanted to bring to your attention. In late 2018, the impact of STDs in the United States, still hidden, getting worse, can be controlled, was a report produced by the National Academy of Public Administration. And the second half of that report came out about a year later, and that was called The STD Epidemic in America, the Frontline Struggle. The Treatment Action Group produced its report. They called it the Pipeline Report 2019, and that very much focused on the pipeline of drugs, diagnostics, vaccines, and the like. And then a first ever federal STI National Strategic Plan was produced just a few months ago, and we were fortunate to have this shared with us in the tail end of our report writing, so that we were able to make some comments specifically about the National Strategic Plan. Next slide. I'd like to turn it over to my colleague from Kaiser Family Foundation, Alina Salganikov.
Alina, you're on mute.
Not the first time. Thank you. What I'd like to do is give you a little bit of background to set the stage for our conclusions and recommendations. STIs are among the most common infections experienced in the United States, affecting nearly 1 in 5 people in 2018, and they're the cause of significant morbidity and mortality. Reported case rates of chlamydia, gonorrhea, and syphilis have been increasing in the US over the past 2 decades. The rate of congenital syphilis, shown here on the right, that is syphilis that is transmitted in utero, rose by 185% between 2014 and 2018. And although diagnostic STI rates have increased across all populations in the US, many groups, including many that are marginalized, youth, women, LGBTQ people, as well as Black, Latino, and Latina, and Indigenous communities, continue to experience a disproportionate share of STI cases in the United States. Next slide, please. Some of the long-term health effects of STIs include infertility, miscarriage, or newborn death, as well as increasing the risk of HIV infection. The CDC estimated that STIs imposed more than $2 billion in lifetime direct medical costs in the United States in 2018 alone. Teens and young adults are also disproportionately represented among the share of cases of gonorrhea, syphilis, and chlamydia. Despite how commonly they occur, their health and economic impacts, embarrassment, shame, and stigma mean that STI epidemics are too often hidden or ignored. Next slide, please. Despite the evidence of the growing burden of many STIs, federal funding to address STIs has remained stagnant, shown here in the blue bars. But in fact, the true value of the federal investment has actually fallen steadily by 40% since 2003, shown here in the green bars. State funding for STI prevention shows a similar pattern. Next slide, please. To respond to our charge, the committee focused its primary emphasis on addressing the growing epidemics of chlamydia, gonorrhea, and syphilis. but the framework we use and the recommendations we make can be applied to a broader range of STIs, including HIV, HPV, herpes simplex, and hepatitis B. I did want to note that preparing this comprehensive report was a major undertaking. We based our conclusions and recommendations on a deep and extensive body of research using a lifespan approach. Our lens is not only at the federal agencies that have programmatic responsibilities, but also to focus on changes that are needed in practice, policy, and health systems in the near and the long term. The committee developed a conceptual framework next slide, please. The committee developed a conceptual framework to illustrate the complex environment and factors that impact STIs and sexual health, as well as opportunities for interventions. I'm not going to go into detail, but the framework's core elements emphasize the importance of interrelated factors. We also considered social and structural determinants of health and health inequities, intersectionality, and recognize that sexual health is inextricably linked to overall health and well-being across the lifespan. Next slide, please. Next slide. Today, we'll summarize the key recommendations of this extensive report into 4 action areas: adopting a sexual health paradigm, broadening ownership and accountability for responding to STIs, bolstering existing systems and programs for responding to STIs, and finally, embracing innovation and policy changes to improve sexual health. Next slide, please. From this point forward, we will highlight conclusions and recommendations from our report. But I want to note that not all the report conclusions and recommendations are included in this presentation, and I encourage all of you to review the report. Next slide, please. The first issue I'm going to address is the need to shift to a sexual health paradigm. Next slide, please. The committee concludes that the persistence and growth of STIs poses a serious health threat. Our current response to address the control and spread of STIs, which is generally grounded on individual risk factors and individual behavior change, has not met the needs of our nation. This approach has tended to fuel stigma and shame, which have hindered the successful prevention and control of STIs. We have largely neglected the social and structural determinants of sexual behavior and health. The focus on the harmful impacts of STIs on women and children has allowed us to largely ignore the impact on men, as well as their role in transmitting STIs. There is a need for public policies on STI control to also address men's sexual health needs, which will not only improve men's sexual health, but may have protective effects on the health of women and children. And finally, because the committee views human sexuality as a vital element of mutual consensual love and pleasure, as well as the fundamental prerequisite for procreation, we feel that in order to successfully control and prevent STIs, a holistic approach with sexual health in the context of a broader health and well-being is needed. Next slide, please. There are many definitions of sexual health, and they are discussed extensively in the report. Here we include the WHO definition, as it includes pleasure, which is central to many perspectives on sexual health, as well as safety and freedom from coercion, discrimination, and violence. Next slide, please. The committee finds that while many actors have a role to play, that HHS needs to take a leadership role. We recommend that HHS develop a vision and a blueprint for sexual health and well-being that can guide the incorporation of the sexual health paradigm across all HHS programs, including the publicly funded insurance programs such as Medicaid, Medicare, and CHIP, as well as public health programs operated throughout HHS, including the CDC, HRSA, IHS, SAMHSA, and the NIH. This plan should align sexual health and well-being with other dimensions of health: physical, mental, and emotional. In particular, HHS needs to develop new approaches and strategies for specifically engaging men and men who have sex with men, as well as strengthening and developing new strategies for improving sexual health services that address the needs of priority populations, such as women, adolescents, and young adults. And finally, to expand attention and resources to underserved and marginalized populations, including Black, Latino, and Latina, and Indigenous populations, people who use drugs, people who engage in sex work, transgender, and gender expansive populations. I'm going to turn it over to my committee colleague, Dr. Ramos, to walk you through some of the other recommendations. Vincent.
Thank you very much. So thank you, Sten. Thank you, Alina. I'm Vincent Guillermo Ramos from NYU, and I'm going to be covering the next two action areas. Can we advance the slide, please? So the first action area that I'll cover is broadening ownership and accountability for responding to STIs. Next slide. The committee observed that responsibility for responding to STIs was too narrowly vested in STI clinics and among STI specialists, which has fueled inadequate attention and resources. The committee concludes that there should be a much broader set of actors across society that should be equipped to bolster promotion of sexual health. Next slide. Among this broad set of actors, the committee recognizes the important role that parents play, and parents deserve special attention as a locus of change, both because of the disproportionate rates of STIs among adolescents and young adults, and also because of the unique and important bond between parents and their adolescent children. This is a unique opportunity to leverage sexual health and for prevention of STIs. Next slide. Federal agencies and relevant professional organizations should equip parents with evidence-based guidance to engage in developmentally appropriate, comprehensive sex health education, and also the HHS, including the CDC and numerous divisions that are identified here on the slide, as well as other federal partners, should develop a national parent-focused communication campaign to promote and guide parental communication with adolescents regarding sexual health and STI prevention. Next slide. HHS, including the CDC, HRSA, and NIH, should develop a compendium of existing evidence-based resources and programs for parental education and skills on adolescent and young adult sexual health and STI prevention. In addition, there should be guidelines developed for pediatric and adolescent healthcare providers that will train providers in sort of meaningful engagement of parents and the ability to support parent education efforts regarding sexual health and STI prevention. Next slide. The committee recognizes there's a need to introduce sexual health into society's lexicon. And given this, the committee recognizes that it's important to encourage broad sectors and key stakeholders across society to really think about what sexual health means and establish their own conception of sexual health that integrates education, prevention, screening, and treatment for STIs. Next slide. The CDC Division of STD Prevention should take steps to expand community knowledge, and that community knowledge needs to be expanded across a variety of settings, including schools, faith-based communities, community-based organizations, workplaces, and families, as I've previously mentioned. Next slide. The next action sort of item is bolstering existing systems and programs for responding to STIs. Next slide. The committee acknowledges that the CDC Division of STD Prevention provides critical leadership in guiding the federal STI response. The committee concludes that the division should be more assertive and in some cases more prescriptive in its grants to states and local jurisdictions in order to establish a minimum national STI standards of care. Next slide. The committee recommends a three-pronged approach: modernizing surveillance activities to enable more rapid release of data, improving timeliness of STI treatment guidelines, and increasing accountability and establishing new funding requirements. And just to pause a second and give some examples, in terms of modernizing surveillance activities, there are numerous examples in the report, but one sort of concrete exemplar would be the use, for example, of electronic medical records. The STI guidelines, the recommendation in the report is that they be reviewed annually and that at least every 5 years there be a comprehensive review of the guidelines and a critical overhaul when necessary. And then also in terms of increased accountability and establishing new funding requirements, that there be benchmarks. And again, perhaps a national dashboard that provides objective and transparent evidence of where we are, where we're going, and where we need to be. Next slide. In addition to federal efforts, The CDC should encourage local health departments to support sort of comprehensive STI plans that are local and help to coordinate the local response. And so you see here, there are 3 bullet points: developing resources and providing technical assistance to state and local health departments and how to conduct meaningful stakeholder consultation processes, developing plans that offer strategic support for improving STI outcomes, and then also assistance in terms of monitoring and implementation. Next slide. Here are some additional exemplars of how local efforts can be supported: conducting community-wide needs assessments, reaching underserved and highly impacted populations, establishing funded relationships with trusted community-based organizations, and then also the establishment of STI resource centers for clinical consultation, for workforce development, and technical assistance to provide support to both clinical and non-clinical STI providers. Next slide. The next recommendation focuses on support and expansion of the STI workforce. The committee recommends that sexual health promotion should be operationalized and prioritized in practice guidelines and training curricula for U.S. health professions. STI prevention and management should be incentivized and facilitated as a focus area of practice for both the clinical workforce and also other important segments of the public health workforce, including non-clinical providers and social service professionals. Next slide. The committee recommends 5 programmatic priorities. Priority number 1, clinical practice guidelines and benchmarks should heavily emphasize the importance of consistent delivery of recommended sexual health services. Some exemplars include the ability to sort of adequately conduct a sexual history, appropriate vaccinations, and also routine STI screening. Licensing bodies for primary care generalists and behavioral health specialists should formulate a minimum sexual health skill set to be reflected in formal training programs. Next slide. CDC and state and local health departments should collaborate in terms of establishing a resource center for clinical expertise. This resource center can provide support to primary care providers and non-clinical health and social service professionals and paraprofessionals. The CDC should identify federal and state policy actions that would more effectively expand the availability of STI workforce and support STI prevention, screening, and treatment. And then also CMS, HRSA, CDC, and other federal agencies should explore public-private partnerships. Next slide. The committee recommends that there be attention paid to the acceleration of research and development for biomedical interventions. To improve the efficacy and reach of tools for STI management and prevention, NIH should prioritize 3 important areas. First, the development of point-of-care diagnostic tests, the development of diagnostic tests for active syphilis, and also the promotion of public-private partnerships for new antimicrobials, as well as expedited development of vaccines. Next slide. Next slide. The committee also recommends that there be greater attention to psychosocial and behavioral interventions for sexual health. HHS should take steps to expand the reach of psychosocial and behavioral interventions to prevent and control STIs at the individual, interpersonal, and community level. This can be accomplished in 3 ways: by developing sustainable funding mechanisms to deliver those interventions, and so moving beyond just project periods, but really thinking about long-term funding to sustain our psychosocial and behavioral interventions, establishing standard guidelines for school-based comprehensive sex education. We know that comprehensive sex education in schools works, and also disseminating community-based approaches. With that, I'm going to turn the presentation over to Dr. Agnor. Medina?
Thank you so much. So I will continue with some key recommendations in the report. So as you know, in order to be effective, STI prevention, testing, and treatment efforts have to reach the entire population. However, because of structural barriers and inequities in the healthcare system, that is not currently the case. And many groups and individuals are at risk for poor STI screening and care as a result of cost, a lack of health insurance, and immigration-based restrictions as well. So in order to achieve population-wide declines in STIs, it is imperative that all people have access to appropriate STI services without regard to their ability to pay, health insurance status, immigration status, or other factors. Next slide. So based on this, the committee recommends that the Department of Health and Human Services, as well as state governments, identify and support innovative programs to ensure that STI prevention and treatment services are available through multiple venues and that opportunities to access STI care are maximized for those who face barriers to healthcare. Priority populations for these efforts should include people who are ineligible for insurance coverage, people who face cost barriers, and people who are unable to access STI services without confidentiality guarantees, such as adolescents and young adults enrolled in their parents' or guardians' health insurance plan. Next slide, please. Yes, I think I just said that part. Next slide. Yes. So to ensure that STIs decrease and that sexual health improves both in the population as a whole and among disproportionately affected groups, we really need to embrace interventions that address structural inequities, including through policy change, as well as technological innovations. Next slide. So first, structural inequities, that is laws, policies, social norms, and societal practices that discriminate against or negatively impact marginalized groups, including LGBTQ+ populations, people of color, immigrants, poor people, are pervasive and pose a major threat to achieving sexual health in the United States. And in order to address these structural inequities, we need structural interventions. That is, public health interventions that alter social, economic, and political contexts, systems, and institutions at the federal, state, or local level, and in turn influence individuals' access to the social determinants of STIs, including things like income, education, employment, and healthcare. However, to date, there have been very few structural interventions developed to address the impact of structural inequities, including structural racism and structural discrimination related to sexual orientation, gender identity, and immigrant status on STIs. Examining and addressing the effect of structural inequities on STIs will require bold vision, long-term commitment, cross-agency collaboration and funding, as well as political will at all levels of government, and importantly, sustained engagement and mobilization of disproportionately affected communities and other key stakeholders. Next slide, please. So based on this, the committee recommends that the Secretary of Health and Human Services acknowledge structural racism and other structural inequities as root causes of STIs and as threats to sexual health. To this end, HHS should lead a whole of government response that engages all relevant federal departments and agencies, affected communities, and other critical stakeholders to develop a coordinated approach to reduce STIs and eliminate structural inequities that are barriers to STI prevention, testing, and treatment, and undermine sexual health among marginalized groups, and ultimately the US population as a whole. Next slide. In addition to addressing structural inequities that drive STIs, the role of technology in potentially increasing STI risk needs to be assessed, and technological innovation in the areas of social media, mobile apps, and AI needs to be harnessed to safely, ethically, and equitably help prevent and control STIs in the US population. In these efforts, it will be important to include industry experts and frequently and regularly evaluate new technological tools, as well as the public's views about them, to determine the best course of action in the ever-changing ethical landscape of technological innovation. Next slide, please. So the committee recommends that the CDC expand its capacity to use technology for STI prevention and control. To accomplish this, CDC should recruit individuals from the private and public sectors with experience in digital behavior change and team science to work collaboratively with agency staff. Achieving this recommendation will require that CDC engage in regular dialogue with leading industry and nonprofit experts, STI providers, and community members, assess its data management capacity, and partner with state and local health departments to use AI-based digital mass communication strategies to better address STIs and STI inequities. Next slide. So as was mentioned earlier, the committee completed its work in the midst of the COVID-19 pandemic, which exposed longstanding structural and health inequities, as well as weaknesses in public health infrastructure and preparedness. The burden of responding to COVID-19 was felt heavily by STI programs, which started off under-resourced in the first place and then had to compete with other programs for scarce resources. All of this led to fewer STI services being delivered and fewer people receiving STI care. So in the aftermath of COVID-19, it is imperative that STI programs be bolstered so that they can engage in their important work at the full scale that is required to battle the STI epidemic in the United States. And because STIs are infectious diseases, strengthening the STI infrastructure and workforce offers the dual benefit of not only achieving stronger STI prevention and control, but also a better positioning the United States for future infectious disease threats. Next slide. So in conclusion, this report and all of the other reports that we base this work on really point to the need to identify and really implement strategies in multiple sectors and communities. And the key point that we want to stress here is that all communities and all sectors of society have a stake in STI prevention and control, and that there are strategies for everyone to engage in. And we have pointed to key examples in the report that focus on addressing issues of equity and innovation, focusing on positioning STIs within the broader context of sexual health. And so this report really provides a roadmap towards not only preventing and controlling STIs, but also achieving sexual health and well-being for all, including as part of a broader population health and health equity agenda that every sector at every level of society can participate in. Next slide. So with that, we are very thankful for your presence today, and I think we are ready to open it up for questions. Thank you.
Thank you to all the panelists. And we do have several questions that have come in already, so let's dive right into those.
So Sten, Stephanie is actually going to go ahead so that you don't have to worry about moderating the chat. She'll go ahead and read those questions for you.
Brilliant, thanks.
Yes, thank you all. And our first question is a two-part question, and it's focusing on a sexual health paradigm as an action that many of us in the STI world have been working toward for years. Are there any scientific data to indicate that implementing this approach has a greater effect on STI incidence or some of the other positive and negative health outcomes than a disease prevention perspective? The other part is, do countries or local jurisdictions that implement a sexual health approach have a lower incidence of STIs over time than comparisons? And before you get to that, I will make one note. A few of the questions are asking about examples, international examples, and the recommendations in this report were largely domestic focused.
We did consider that exact question. And of course, it's hard to randomize populations or states to have one sort of attitude versus another. But if one looks ecologically, the Western European nations, particularly the Northern Western European nations, have taken a very strong sort of sexual health strategy. There is assertive health education in classrooms, guidance for parents, and a strong preventive measures. So these are societies, Sweden is often highlighted for its success, that whose sexual activity indices in, say, adolescents, young adults, and others are similar to the US, but the STI rates have been driven down to extremely low levels. And you've even had the phenomenon in places like Sweden where the sexual revolution, for lack of a better term, has resulted in liberalization of sexual activity. However, STI rates have dropped at exactly the same time. In the US, we do have states that are sexual health friendly and states that are more reluctant to include this in school curricula. And there have been several studies to suggest that the more information that youth and young adults have, the lower their STI rates and pregnancy rates are. So that's perhaps not strong enough evidence for some, but I believe that it's consistent with the advice that we're giving and gives us some scientific anchor for that advice. Happy to hear from other committee members. Case?
Yes, thank you. That's such a great and important question, and Stan is right, obviously, that it's not very easy to study these things, given the different sort of backgrounds in different communities. I would want to add, though, that I think there are reasons to take a sexual health approach that go beyond necessarily scientific evidence. The committee goes at quite some length, actually, to paint a sort of ethical framework on why it is important to go this direction, that things like beneficence, non-maleficence, justice, particularly sexual justice, autonomy of decision-making, those kinds of things, actually a sexual health sort of approach fits better in an ethical framework like that than a disease prevention. And so this is, the committee sort of goes into quite some detail, particularly in chapter 1, but also in other chapters, about sort of providing that as a framework and as a background for their approach. Thanks.
Thank you. Our next question is for you, Vincent. We can imagine most adolescents will feel uncomfortable or try to avoid having STI-related conversations with their parents. Are there recommendations or guidelines given to parents or guardians for how to combat this?
It's a great question. So thank you to whoever asked that question. So I guess I want to answer that a couple of ways if I can. I think the first point I want to make is that the committee really wanted to highlight aspects of the report that are innovative. And if we think about, as a country, how we've responded to STIs among adolescents, the dominant approaches have tended to focus on adolescents directly. They focus on interventions like clinics or school-based, community-based, increasingly media campaigns and things like online outreach. Those are all terrific and we should do those things. But what's really interesting is that time and time again, research supports that young people say, including adolescents, that their parents are very instrumental in terms of their sexual decision-making and their behavior. And yet, when we really look at the landscape of existing interventions, there's a real absence of sufficient parent-based interventions. And so one point I want to make is that actually young people are saying the opposite. They're saying, and the research supports this, that they want to hear from their parents and they want their parents to be involved in appropriate ways. That's not to say that every young person will have the ability to involve their parents, but the vast majority of young people will be greatly benefited by the inclusion of parents in ways that make sense and that are appropriate, that respect confidentiality, young people's autonomy, but that also take advantage of the unique influence and potential partnerships between healthcare providers and also partners in non-clinical settings that are also key actors in terms of leveraging parent influence. I will say, just to also build on the sexual health question by making a point about parents, imagine a country where sexual health was really discussed within the family and everyone had an opportunity to really talk about this in a way that was normative. Would we see differences and changes in the kinds of inequities that we're experiencing and have been experiencing for quite some time?
Thank you. Our next question is for you, Sten. We're hoping that you can discuss the American Rescue Plan Act and whether you think your principles will be adequately addressed or funded. Do you have plans to advance this report with relevant members of the CDC and HHS?
Just as a reminder, this report was commissioned by the CDC, so they are our primary audience. However, as with all NASEM reports, it's available to everybody for free, and we have many comments that refer to other federal agencies to try to be helpful to them as well. So the American Rescue Act is, as you all know, a vital part of COVID reopening efforts and revitalization of our public health infrastructure. Section 2404 is called Funding for Data Modernization and Forecasting Center. And there is an appropriation of $500 million. This is guiding the director of the CDC to support public health data surveillance and analytic infrastructure modernization. And this is going to try to help us with early warning systems for emerging diseases to forecast and track COVID-19 variants, emerging biological threats. However, all of us think that there is a strong tie, and we comment on this in the report, between things like STIs and HIV, COVID public health response, STI public health response. These are not divorced topics. They are highly integrated. And we believe that this is an invitation with substantive funding that CDC has not had in generously previously, that may enable innovation around electronic data systems, exploitation of social media for surveillance, early warning signs, upgrading traditional surveillance, lab-based surveillance, and many other examples. So the answer is yes, the American Rescue Act is an important contributor, and given current CDC leadership, we have every faith that they will look for opportunities to engage not only an improved response to emerging infections like COVID, but also re-emerging infections like the STIs.
Thank you. Our next question is for you, Medina. Does the report address the duality of how to highlight higher risks in vulnerable populations while minimizing the risks of heightened stigmatization?
That's a great question. Thank you for asking it. And I think, you know, that's an issue that is pervasive in research on health inequities more generally. But what we've really done in the report is to focus on priority populations that were disproportionately affected by STIs as a result of structural and social determinants of health. And we've use this conceptual model that really shows how structural inequities underlie STI inequities. And so what we also try to do is include structurally marginalized groups that haven't been included in other STI reports, either because they were smaller populations or because their needs there hadn't been research on their needs in the past. And so we kind of focused on that. And in talking about STI inequities, we really contextualized all of the findings in social and also historical context. So you'll see really careful attention to not situating the causes of STIs within individuals or communities, but really thinking about the role of social and historical context in driving those inequities. So that's kind of been our way of balancing both of those issues.
Thank you. The next question is, could you point out how this report differs from the 2021 to 2025 STI National Strategic Plan that was released last December? Oh yes, and that question was—
Case, do you want to take that?
I'll again take a stab at that question. So thank you for asking, because clearly there have been a number of reports that have come out in this last year alone. And as was said in the presentation, we had an opportunity to look at all those reports and try to respond to some of these and expand beyond what is in those reports. I would say that our committee really envisions a new paradigm that puts STI prevention into the much larger context of sexual health and sexual well-being. So not considering STIs as just an isolated problem affecting distinct high-risk populations, but rather as a societal problem that requires societal solutions. And it also recognizes, and I think this is really where it goes beyond what's in the other reports, that it recognizes the importance of engaging actors beyond traditional public health and STI clinics in the prevention and control of STIs. For example, as was mentioned, the fact that a disproportionate number of STIs occur among the youth and young adults, it's really imperative that we involve youth, their parents and educators in program development and implementation. And another corollary to that is that, especially in areas with high STI morbidity, it is important to listen to, it's critical actually, to listen to advocates, to faith leaders, other stakeholders, and involve them in a meaningful community engagement process. And I think there's a lot of that in the report that sort of, looks at the stakeholders in the communities and involve them in a more holistic sort of program.
Thank you. Alina, our next question is for you. Where does the committee see the role of family planning providers in STI prevention, particularly given that the responsibility for responding to STIs tends to be narrowly vested in STI clinics?
That's also a terrific question. Thank you for asking that. Family planning providers have been on the front lines of providing STI services for women across the country. Title X and Medicaid are a critically important part of funding that whole infrastructure. And the family planning, I think the family planning providers have a lot, they have a lot of experience and a lot of knowledge and are a critical part of the workforce that we discuss in the report in terms of bolstering and strengthening the workforce for family planning services, as well as for sexual health services. So I think they have a critical role, and they have been actually doing a lot of work in STI prevention and control, but clearly the resources are quite limited for family planning services in the United States, and STI services is a part of that. So we really need to acknowledge that their role is important and that they need to be resourced to provide those services.
Thank you. Our next question is for you, Vince. There's some surprise that the word condom wasn't used in the presentation, but promoting condom usage is one of the most important public health interventions that can prevent STIs. Is condom promotion included in this report? And is there a place for condom promotion in the sexual health paradigm?
So really great question. So I would actually, that's for me, Stephanie?
Yes.
Okay. So I would say that condoms are absolutely part of the sexual health paradigm. I think it's a multi-purpose prevention technology that's good for unplanned pregnancy prevention, STIs, and also HIV. And so really important to recognize that in the United States, among high school students, there's been a steady decrease in condom use. And so certainly part of what we're arguing in the report is that we need to sort of bolster all of the existing psychosocial, behavioral, and biomedical intervention tools that we have, condoms being one of them, and that sexual health means delaying sexual debut, but it also means if you are sexually active, and many of us in our lifetime, actually most of us, will at some point in our lives become sexually active, that we can have sex in ways that reduce risk and that protect us, and condoms certainly are a fundamental part of that.
Thank you. Our next question is another two-parter for Keys. So it's about testing and contact tracing. So we know contact tracing played a large role in STI control. What role should it play in the future, particularly taking stock of what we learned from COVID? And then Labs are saying they would have to do validity studies. So with telemedicine, a patient going to LabCorp, they might not be able to self-collect. Are there any suggestions in terms of the processing of patient-collected specimens?
In terms, sorry, what was the first part of? I was focusing on the second part. The first part was.
Yeah, the first part was about the role of contact tracing and STI control.
Right.
What role should it play in the future?
Yeah. Yeah, so that's obviously a very timely question because of the role that contact tracers have played in the COVID epidemic, and actually have drawn away from this critical resource in STI prevention, because clearly the disease intervention specialists have been very active in prevention activities in the overall STI prevention effort, and sort of seeing those resources being drawn into a different direction obviously was not a good thing for STI prevention. I would hope that as part of sort of the hopefully the expansion of public health as a result of the COVID epidemic will actually sort of start to focus again on the importance of disease intervention specialists and these types of interventions, which will continue to play a very important role in STI prevention. So thank you for that question. It's definitely something that the report talks about. In terms of testing, clearly another thing that has been affected by COVID and discontinuation or really reduction of clinical services has led to some innovations in this area, particularly in terms of home testing, for example, and self-collection. So this is an area that I'm sure as we sort of come out of the epidemic and start to sort of look at our clinical services again, is something that we will continue to look at and sort of see what the role can be of home testing. The other thing that the report talks about extensively is the development of STI point of care testing, and a number of these tests sort of coming on the market, and what point of care testing not only can do in the clinical setting, but what it can do for home testing, and clearly the effectiveness of these approaches need to be evaluated.
We have a few workforce related questions that came in. I'll direct those to you, Vincent. So the first is, what is the role of community health workers, CHWs, in STI prevention and control? And then how can health or allied health programs be modified to start better educating providers and healthcare professionals on taking a sexual health history and addressing implicit bias surrounding sexual behaviors?
Let me take number one and turn it over to Vincent for number two. So for number one, the community health worker question, the committee is very enthusiastic about the data that we reviewed around the benefits of what's sometimes called task shifting. So if we don't have enough doctors attending to STIs in America, if we don't have enough nurses to accommodate the need, can community health workers fill that gap? And peer guidance, peer counseling, peer-to-peer advisory can be far more effective in many cases, than, especially in vulnerable and disenfranchised populations. So there are a number of states that are innovating in community health worker. It's kind of sad because it's like reinventing the wheel from many, many years ago. I'm thinking of Emily and Sydney Kark in South Africa, or the Barefoot Doctor in China, or so many examples in the US, Jack Geiger and the programs in the Mississippi Delta. So we seem to have to reinvent the wheel, but if we can have a revitalization of community health worker engagement. Those persons can be recruited from the community. They can speak the language of the community. They can engage, much as we've seen in the HIV field. They can engage much more effectively than many others. And there are also complexities around whether community health workers can have standardized training, whether they can have licensure, and whether there can be reimbursements that emerge from government and private health plans, so that these positions are sustainable. They're not simply a foundation grant that comes today and goes tomorrow, but are actually anchored in our health system.
So thank you, Sten. That was a great intro to the response. So I'll just add a couple of things and I'll respond to the second part of the question. So I think the committee recommends that the STI workforce, and certainly community health workers are a terrific example, but that the STI workforce be expanded and broadened. And I think historically it's been much too focused on folks who deem themselves as STI specific providers. The report recognizes that there are clinical providers, there are also non-clinical providers. There's a real effort to acknowledge some strategic opportunities. One of those opportunities, for example, in the clinical space, is the important role of pharmacists. There's also recognition of nurses as the largest segment of the public health workforce, totaling more than 4 million. And I think Sten has highlighted sort of the role of task shifting and some of the ways in which we can better sort of leverage our existing public health workforce broadly. That includes, you know, all of the usual actors, but also moves well beyond that and includes many non-traditional partners, including community health workers, all sorts of paraprofessionals, and researchers, policy experts, et cetera. In terms of training, I think there was a question about training programs and about sexual histories. The committee recommends that there be real attention to pre-licensure training programs in health professions and also behavioral and social service professions that really specifically addresses content around sexual health and ensures that there's a minimum standard that is met. In addition, once folks are practicing in their respective discipline, that there be ongoing sort of training and support to ensure that what we learn as healthcare providers that we don't forget over time, or that the realities of our practice and the kinds of demands that we're faced in our clinical settings, that doesn't in some way alter some of the best practices that we know that we should be implementing, you know, with our patients. And then this issue of bias, I think it's widely recognized both in other reports by the national academies as well as in the broader literature. Our committee also discussed it quite explicitly, that there needs to be recognition that bias can influence a person's experience in the healthcare system, and that needs to be addressed directly. There needs to be special efforts, training that will help providers of all sorts to really look at bias and how it shapes outcomes for the people that we serve.
I recognize we're coming up on time, so I'm going to ask our panelists to give lightning round answers here. For Case, this question is for you. Much of CDC's data is gathered from state and local agencies. Can it move to directly collecting from large electronic health record databases like Kaiser Permanente, for example, to get closer to real-time data over months or years?
Yes. Thank you. Another topic that has been discussed pretty extensively in the report, particularly the use and the expansion of electronic medical records, and how the data that is collected in these can be used in further tracking STIs. And so there are numerous ways that we feel that, you know, there are other data sets, and also using AI sort of techniques in sort of getting at these types of data. I would like to reiterate, though, that that just numeric counts are problematic in the sense as you know, as we've, for example, seen with COVID. that we know that the rates are really dependent on testing. The more we test, the more we find, and so that's going to happen with these types of data, and our surveillance is really focused on case counting as well. And so I would like to create the importance of having additional studies that are looking really at population-based, prevalence and incidence.
Thank you. And then we have a final question. This goes for you. This goes to you, Medina. Have we considered, advising, taking a sexual health history a mandatory part of primary care, giving it, priority A rather than priority B? And could you kind of go into the ethical framework around that?
Sure. I think that we need to think about strategies at multiple levels, including at the patient provider level, and thinking about guidelines related to sexual history taking, and what that looks like in the clinical setting is absolutely important. And Vincent gave us some nice recommendations, and you'll see more on the report about primary care settings, about training healthcare providers to really address STIs in a holistic way within a sexual health framework. And I also would like to add that in addition to thinking about what happens within the clinic, we also need to think about what happens outside of the clinic. And the report also really stresses the importance of thinking about health as well as social policies that shape the social determinants of health. And we offer a whole host of structural interventions that decrease marginalization, stigma, and promote access to various social, economic, and healthcare resources across population groups. So I'd encourage us to think about all of this within the context of a multi-level intervention framework that all of us can kind of take a piece at each level and sector of society to really make an impactful change to promote sexual health more broadly.
Thank you. And it looks like those are all the questions we have time today, since we went a little over, and I thank you all for joining. I do apologize if we didn't have time to get to your question, but once you exit this webinar, you will be redirected to our report page that also has a study team contact information. And once again, you can download a full PDF of the report for free at nationalacademies.org/prevent-STIs. And again, slides and recording of this should be available on that page within a week or so. I'd like to thank all of our panelists today, and thank you all again for participating. Have a great rest of your day.